if I can ask for every participant, or not the participants, but the registrants, to mute their mics while we're going about our presentation tonight, that would be extremely helpful. Same goes for the cameras. It would be rather helpful for us, at least, to give you guys the best that we can. So without further ado, let's get this started. Alrighty. So yeah, everybody, good evening and welcome to our online webinar. We're just going to wait for a few minutes to allow more registrants to come in and settle. We'll be beginning momentarily. Thank you for your patience. Mary Ellen and Dr. Ibrahim, are you guys okay with 6:05? We still have people rolling in slowly.
Sure.
Yeah, that should be okay.
Cool.
That happens in real life.
Tell me about it. The party doesn't start till, half hour later. That's what they always say.
Well, and some people may have traffic getting home or wherever too.
Very true. Very true. Hopefully traffic's not too bad and everybody's able to make it on time, or at least relatively. But seems to be everybody's coming in. We're gonna have a good time tonight on this one. Lovely weather we're having though, right?
Oh my God, gorgeous.
Beautiful.
On a day like this, I wish my office was outdoors.
Don't we all though? Don't we all? Holy moly. It's gorgeous.
I think I'll put a patio in my budget.
It'll be worth it. It'll definitely be worth it. To go out, do a little bit of work, get some things done, and enjoy the views and the weather. Nothing better than that, at least for me. At least for me. All right. Give her a couple more minutes, and we'll be set.
Almost 5 minutes after the 6, so maybe we should start.
Alrighty, let's just get it started. All right. Good evening again, and welcome to Christiana Institute of Advanced Surgery's Weight Loss Seminar. For tonight's presentation, it's truly our pleasure to introduce you Dr. George Ibrahim, as well as Mary Ellen Sparks, whom is the program coordinator and manager of the St. Francis Bariatric Program. Mary Ellen, if you would like to take it from here and present your slideshow.
Good evening, everybody. Thanks for coming. I'm gonna do a little kind of commercial, just so you know a little bit about St. Francis. We are a MISQUIP accredited bariatric surgery nutrition center. Our focus is to provide an excellent bariatric surgery experience for all of our patients. The top 10 reasons to choose St. Francis for your surgery is we are accredited, which recognizes excellence in surgical skill, patient care, and positive patient outcomes. We were accredited originally in 2007. We have been reaccredited in 2011, 13, 2016, and 2019. We do not charge a program fee. Some programs charge money out of pocket beyond what your insurance covers. We do not do that. We have 2 locations. We are right next door to the CHRIAS surgeons, Dr. Ibrahim, Dr. Wynn, Dr. Irgau, Dr. Peters, and Dr. Singh at the Apex Medical Center in Suite 103. We also have an office at the St. Francis Hospital in room 429 in the cardiac rehab. We are doing both in-person and telehealth appointments. We are committed to support group. We have it the first Tuesday of every month from 5:30 to 6:30 p.m. We are not doing the online support group. We're actually doing the live support group, and you need to call an RSVP because we can only have 12 participants at one time. We do not do a support group in December. The next support group will be Election Day, November the 3rd. Flexibility, you can start the program at any time. As I said, we're doing in-person or telehealth. It's your choice. We have appointments 7 days a week, as early as 7 a.m., as late as 7:30 p.m. And what we're providing for you in Apex or at St. Francis is medical nutrition therapy. You also have access to nutrition follow-up in person, by phone, or email after surgery. We do have a vitamin program that might be covered by your insurance. When you do come, we check that out for you. We have weight loss surgery success classes by a licensed psychologist, Dr. Lisa Slade Martin. She's doing independent study and your insurance is billed. We have private rooms at no additional charge. We've always had private rooms. This is what the room looks like. It's very spacious. And best wishes for a safe and successful weight loss surgery experience. I will turn it over to Dr. Ibrahim.
Thanks, Mary Ellen. Thanks, everyone, for coming tonight. Really appreciate that. Well, I'm going to hold you down for a long time. I'm trying to make my talk brief and concise and as clear as possible, too. First, I would like to start by introducing our group, the CHRIAS group. And as you see, we are a total of 5 bariatric surgeons in the practice, with experience spanning almost 20 years in bariatric surgery and minimally invasive surgery. We do specialize in laparoscopic and robotic surgery. We are the first in the state to perform laparoscopic and robotic bariatric surgery, and we have quite extensive expertise in revisional surgery. Our area of expertise also include other operations like gallbladder surgery, hernia operations, colon surgery, and anti-reflux procedures. Now, after this little brief introduction, let us talk about why you are all here tonight. So, what's obesity? How obesity looks like, or how can I tell someone is obese or not? To answer that question is obesity. In fact, the most accurate scientific definition for is excess body fat. To calculate body fat, that requires doing extensive testing in a specialized lab, which is not practical. So what we usually use is something called body mass index. It's a ratio between weight and height. There is online formulas for that. They are available. There is apps you can download on your iPhone or Android. They're free. And all you need to do is just put your weight and height, then the number comes up, which is the body mass index. And normally this number should fall somewhere between 20 to 25 or 19 to 24. This is the normal body mass index. Above that, we call that overweight. Once it hit 30, that's obesity. And once it hit 40 or above, that's what we call severe obesity. Why is this important to know? Because let us say someone have 10 or 20 pounds above their normal weight. Does that justify surgery? I guess the answer is no. Of course, surgery is a big decision. It's a big deal. And you should target really someone who's having a big problem. So when you come for bariatric surgery, we are targeting people with body mass index 40 or above. What about if I'm not 40, I'm 39? Should I wait till I get sicker and more obese and to get surgery? The answer is no. Between 35 to 40, there's exceptions made if obesity already start to cause damage to your body. What do I mean by damage? Like medical problems, such as diabetes, high blood pressure, sleep apnea, etc. So if that's the case, you also still qualify for bariatric surgery. Now that we agreed on the definition of obesity and who qualifies for surgery, to solve any problem, you have to go back and look to the source or the root of the problem. And to be honest, 50 or 60 years ago, we didn't have this obesity issue. Life was much different. It's a very active lifestyle. We didn't have cars everywhere and machines and computers and elevators. We had to exert ourselves. Even at home, normal activities, cooking a meal or washing dishes or clothes, required some sort of mechanical labor to a certain degree. So that's a factor. Another factor also is the diet itself. Back in the day, things were fresh. You had to cook your food at home. Now everything is processed, ready made. We have microwave dinners, fast food, and you can just go to a vending machine and grab something on the go. Metabolism, of course, there is factors related to that. There's obesity that runs in families because of genetics and just how the metabolism is. And it's a behavior, it's a learning. Everything we do is something we learn from our ancestors. This is the way how we used to eat at home. So some families, their diet is just pretty much heavy on carbs, bread, pizza, lasagna, stuff like that. So there's so many factors. It results in obesity. Now this problem has been propagating, and the number of obese individuals has tripled in the last 50 years. It's estimated now that at least 30% of our people in the United States are overweight, and 12 to 15% are obese. So this is in fact much more common than the coronavirus. So what's the big deal? What if I'm obese? What if I'm having more weight on me than I should? It's just about how I look. I don't care. I'm comfortable in my skin. Well, the issue is not your weight, is not the number of pounds. It's what this weight does to your body. And you just think about it in a simple term. If you have any equipment or a machine or a car and you overuse it, what's going to happen? You're going to break early. The same thing happens to your body. You can point anywhere in your body and there was damage that can happen from obesity. Your blood sugar will go up with obesity, so you are diabetic. Your cholesterol will go up, so you get atherosclerosis. These two things will lead you to high blood pressure, and the three of them will give you coronary artery disease, heart attacks, myocardial infarction, strokes. So obese individuals compared to non-obese people live shorter, between 8 to 13 years. And this is all research. This is all proven science. Your breathing is tougher, it's harder. You get winded easily with minimal exertion. Headaches, depression, and anxiety. Because of course of all the stereotyping, being judged. Sometimes you get a young person, 18 or 19 years old, and you ask them when you start first noticing I'm having obesity issues. Well, since I was in 3rd grade, kids used to make fun of me in school, which is brutal. Reflux, yes. Infertility issues, polycystic ovaries, joint problems, stress incontinence. There's in fact 13 different cancers can be triggered by obesity, or you are at high risk of because of obesity, including breast cancer, uterine cancer, ovarian cancer, stomach cancer, kidney cancer, liver cancer, adrenal cancer, some blood cancers, and the list is growing. So obesity is a big deal. It's not just how I look in the mirror. It's not the size of clothes I buy. It's not the seat in the airplane that I can't squeeze in and I feel embarrassed. It's much more important and deeper than that. All right. So what we are going to do, there must be solutions and we must do something. Well, here's the options. Diet and exercise. Now, I'm sure everyone in tonight's meeting at certain point tried diet and exercises over and over and over. And I'm sure you tried all the available commercial stuff, Herbalife, Weight Watchers. Dr. Oz recommended the supplement. I tried the keto diet, intermittent fasting. I went to that program. I lose and I gain, I lose and I gain, up and down, up and down. I lose 10, I gain 15. I lose 15, I get 20. The problem is just getting bigger and bigger with time. What about medications? A lot of people I ask, oh yeah, my family doctor put me on some medication. What happened? Oh, side effects were bad, or it didn't work, or it worked for a short period of time. Then the moment I stopped, it came back with vengeance. And by the way, we require that you try these things before you come for surgery, because you have to be sure that nothing else worked before you take that step. So if you hear me ask you, what did you do before? Don't be surprised. We're not trying to discourage you or anything, but you have to reach a conclusion that, yes, I tried everything else, and this is my last step, my last resort. And it's sometimes sounds counterproductive or counterintuitive. I mean, when we talk about the efficacy of surgery and we compare it to medications or diet and exercise, it's a huge difference. For example, if you go on medications, you might lose 10% of that excess weight. Like I have 100 pounds on me, I lose 10 or 11 pounds in the next 3 years on medications. While with a bypass or a sleeve surgery, you will lose anywhere between 70 some to 60 some, which is big difference. And the same thing applies for diet and exercises. So we have a big problem and we have a big solution for it. It's a big decision, but it's the only effective decision. Okay, I'll go back to what I was talking about earlier. Who would qualify for surgery? Anyone? I have 10 pounds I want to lose. Should I get surgery? Of course not. To qualify for surgery, your body mass index has to be 40 or above. How will you calculate that? It's the ratio between your weight and height. What if I'm not quite there yet, somewhere between 35 and 40? God forbid you have diabetes, high blood pressure, sleep apnea, you qualify for the surgery. That's the first condition to meet. You have to be an adult, able to understand and comprehend the surgery, so 18 years or older. You have tried and failed diet and exercise, okay? Because surgery is not an easy decision. So you have to be yourself fully convinced I tried everything else and it didn't work for me, okay? Also, you have to be in reasonable shape, okay? I mean, there's no point of trying to help you lose weight and improve your quality of life and you have terminal cancer or terminal heart failure. Pretty much anesthesia will kill you. So there have to be acceptable risk for surgery. And more importantly, the key to success to this is you yourself willing to commit to lifelong change in diet and habits. Surgery is just a tool at the end of the day. If you don't use it properly, it's never going to work. It's exactly like driving a car. You have a license. To get that license, you have to know the rules of the road, take your test, get your permit, go on a road drive test, pass and get your license. Once you get your license, you still have to abide by the rules. You break them, you lose your license. Same thing. Preparation for the surgery process will take a few months. Now you qualified and you earned it, you get the surgery, you have to follow the rules. Otherwise, the weight you lose will come back down the road. Okay, options. What are the surgeries we can do? There's quite a few of them. We're going to talk about the 3 most common ones in the same sequence of the most common to the second common to the least common. Now, to make the surgery principles easy to understand, just think about your stomach itself, the organ. When the stomach is empty, it's very small. but it has an ability to stretch way and beyond. Think of a little balloon. You buy a balloon, it's very small, it can fit in your palm, but when you put air inside it, it can become huge. Same thing happens to your stomach. So when we sit to eat, the first thing you go out, we ask you, want to drink something? Yeah, sure. What do you want for appetizer? Chicken wings. Okay, what do you want for your main dish? Take a cheeseburger, fries, and another drink. You want something for dessert after? You want coffee? Now you spend 2 hours, you eat, you had a good time. But if you stop for a second to think about all that food and drinks you had, it's a big quantity. Where all they went? Inside your stomach. So it seemed to us the source of the problem is the stomach itself. It doesn't know when to stop. And here comes the surgery. What the surgery does is help you control your stomach. How? Find a way to prevent the stretching or the expansion. One way of doing that is a procedure called sleeve gastrectomy. It's the most common performed surgery in the United States and in fact around the world. Why? Simple, easy, effective, and safe. The idea of the surgery is to go on the stomach itself and divide it from point A to point B, all the way up and down. Then that part here on the right of the screen, we remove completely out. What stays behind is that area of your stomach which does not stretch. In other terms, I'm removing out the stretching part of your stomach where all the expansion happens. After the surgery, your stomach cannot stretch anymore. So a very small meal will make you really feel full. How small? Half a can of tuna can stuff you up. Surgery done laparoscopically by small cuts. And in fact, I do have a video here to show to you how the surgery is done. Okay, now we don't do any big incisions anymore. That's something went on for years and years. Now it's gone, it's archaic. What we do is called laparoscopic or minimally invasive surgery. So rather than making big cut on the stomach to get inside and do the procedure, we do very small incisions, few of them, 4 or 5 of them, keyhole incisions. And what we do, we put tubes inside these incisions. Now these tubes act like tunnels, and I can put my instruments in and out many times as I want until I'm done. Then I pull these tubes out and close the incisions. Now, when we go inside, the first thing we do, we examine everything. We look to your liver, to your stomach, to your intestine, make sure everything is fine. Then blend the procedure. Now, remember, in a sleeve, what happened is we're removing the area of your stomach where the stretching happens. So this is your stomach, and it can fill up with a lot of food, almost 2 pints of food at one time, easy. So what we go and divide your stomach like that, up and down. Then remove that part on the right of the screen. Now what stays behind of your stomach looks like a sleeve of a coat, hence the name sleeve gastrectomy. And pretty much your food will go through the natural passage. We are not rerouting or changing the direction of anything. And what happened, you just now have control on your portions, you're eating much smaller amount of food, and this what help you to start losing the weight. Now you compare your small stomach with your original stomach. Okay, that's one option. Another option, something called gastric bypass. Now, gastric bypass is one of the oldest surgeries in the book. And it follows the same principle. We're trying to control your portions. But rather than cutting or removing any part of your stomach or intestine, we're going to create shortcut around your bowels or a detour around your bowels. How? So we go on your stomach and we divide your stomach up here like that, but not removing anything, just dividing your stomach. So when you eat your food, it goes down your esophagus to your small portion of your stomach, and because it's really small, maybe 10% of your stomach, again, small meal make you really feel full. Then we go down, bring your small bowel up and connect it to your small stomach. So the food will go from there down to your intestine right away without going through this part of your stomach or bowel, hence the name bypass or detour around your stomach. We have a video for that, so I'm going to share that with you. And the same thing, no big incisions, no big cuts. We don't like them anymore. All we do is minimally invasive, small incisions. heal fast, no complications, no infections. Go home the same day or next morning. Recover quickly, doesn't hurt. And the same thing, we go in, examine your intestines, stomach, bowels, and everything. Then we start first by cutting your stomach up here. It's going to create two stomachs. One that receives the food, we call it the pouch, and the other one that doesn't receive anything, we call the remnant stomach or the excluded stomach. And here it is. We go and divide your stomach up here in that area. Upper stomach, lower stomach. Then we go down your intestine, bring a piece of it up and go up all the way and connect it to your smaller or upper stomach. The other end of the intestine downstream, we connect it to the side so it can empty all the secretions and acid and other things. We are not removing anything in comparison to sleep. Now you see, the food will go down here to your small stomach, then to your intestine down here, bypassing this part of your stomach and intestine, hence the name bypass. I'm eating less food and I'm not digesting everything because of the bypass. So this is why I lose weight. Okay, any other options? There is something called band, but now it's very rarely done. Used to be popular 10 years ago or so because it was simple, not cutting any stomach or intestine. But problems came after years because in a band, what we do, we're implanting hardware inside or a foreign part. The idea is simple. Rather than cutting a piece of the stomach to make it smaller or rerouting food around your stomach, what we do, we implant a balloon and we wrap it around your stomach here. Balloon have a catheter and the other end of the catheter is implanted beneath the skin. Then we have a special needle that we use to access the catheter and inject water inside the balloon. So when the balloon gets bigger, kind of squishes your stomach and make the inside of your stomach very tight. So when the food goes down, it doesn't go down easy. It gets stuck in your food pipe for a little bit, then slides down to get digested, and you feel full very soon. You just take a couple of bites and you feel, I'm already filled up. I don't need any more food. Used to be popular because, again, not cutting any stomach or intestine, simple to do, go home, and life is good. But the problem came after years with it's hardware, it can break, it can move, can get infected, need to be replaced, which means another surgery. Also because when you make these balloons tight around the stomach, sometimes swallowing is not easy. So we fill it up, you come back and say after a couple of weeks, I'm getting a lot of reflux, can we loosen it? So we loosen it, weight comes back. So the amount of weight you lose compared to sleeve or a bypass is not really great. Maybe half of that what you have lost with a sleeve or a bypass. So with time, it kind of fell out of favor. Now sleeve is number one, bypass is number two. Okay, so we're gonna want to do one of these surgeries just to lose weight. No. To improve your quality of life. Remember, when you lose that weight, diabetes is gone, high blood pressure is gone, cholesterol gets better, your risk of heart attacks, coronary artery disease, strokes, cancers. Now you can get the surgery for your knee that your orthopedic surgeon said, no, you are too heavy for this. Some young ladies come because they're unable to conceive. Next year, they're having a child. This is why you're doing this. I can now travel, go and see my grandkids, go on the trip I wanted to go with them. I can do things I was unable to do before. So that's the real reason you do surgery. Now, so after tonight's talk, you think about it and you decide, I want to do this. How do I start the process? You start the process by meeting one of us in the office. We go one-on-one. We usually do now meetings by telemedicine or virtual meetings like tonight's. And if you're unable to do that, we can meet one person too. We discuss your health needs, what's going on, help you choose the surgery that you think will be safe for you. Then based on that, there are some requirements we have to fulfill so your insurance covers the surgery for you. First, you have to see medical nutritionist specializes in the surgery, like St. Francis program Mary Anna was talking about earlier. You have to see a certified psychologist. There's some blood work needed. Then depends on your medical history. You might just need to see your primary care doctor before the surgery. Some other people might need to see a heart or lung doctor. Depends on what's going on in their life. And once all these things are done, we get you approved for the surgery and we go ahead with it. So it's a process, it takes a few months, but this is time very well invested for you to understand the surgery, the life change needed after, and pretty much make sure you have all the support you need for success. And that's pretty much conclude my talk. Thanks for coming tonight, and we are open for any questions.
Thank you, Dr. Ibrahim, for the very informative presentation. At this time, like Dr. Ibrahim said, we're opening the session for questions. Please utilize the chat function at the bottom of the Zoom screen if you do have questions. But in the meantime, Dr. Ibrahim, do you mind telling us about the importance of being an accredited surgeon and facility?
That's very important because we live now in an era when there's specialization for everything. Okay, back in the day, you could go for a surgeon and he will do weight loss surgery, breast surgery, thyroid, colons. This is pretty much was when we had the term general surgeons. Now, you have to realize these are very delicate procedures. You have to have someone who is very well experienced, very well trained to do that. I spent an entire year of my life just learning how to do that in a fellowship in a high volume center where they do 500 surgeries a year. Now, you need this expertise to optimize your process to make sure that you go in and out of the surgery safely, no complications, no risks. Also, you need to know someone who able to do these surgeries correctly so you get the results you want. And sometimes, unfortunately, we get someone who come from another place and you say, what happened? I had the surgery, I lost a few pounds, then I had these problems, then they come in for a revision or requesting opinion to help them solve a problem that happened before. So it's very important when you pick up a surgeon, you pick someone who's having experience doing these surgeries, have good background, trained, and did a lot of these. Also, all the places we work at are now centers of excellence, which means anesthesia staff, nursing staff, coordinators, dietitians receive the highest training possible and they're following the highest standards of care.
That's extremely interesting, actually. We do now have a question in the chat. One of the registrants says, "Hi, doctor. After the surgery, how long is the recovery process? I have a desk job and was wondering how much time I would need off, considering the sleeve."
I would say give yourself 2 to 3 weeks to be able to go back to your job. Now, there's individual variations in that. When it comes to recovery, there's so many things you have to think about. What do you mean by that? You mean able to drive your car? Most of people, 7 to 10 days. Going to the gym. After 2 weeks, you can do treadmills, bikes, ellipticals. After a month, you can do weights and crunches and push-ups. Going to work, this job, give yourself a couple of weeks to 3 weeks. More physically demanding job, 4 to 6 weeks. I've seen people deviating from that. I had once a patient after a bypass, went to work 6 days out. Spent an entire 8 hours on her desk and she did great. Okay, so pretty much the average 2 to 3 weeks after with a desk job kind of thing. And if you feel better before that, we can release you earlier. If you need more time, we can always extend that too.
Hello? Very intriguing. Hello.
Yes, I got a question about the last one, the band in the stomach. Is gonna stay in a hospital too many days? Is no cutting, no nothing. I want to know the operation and what you're doing after the operation. Is it stay in a hospital or it's going in the
Well, it
same
depends
place?
on your health in general. If you have heart problems, lung problems, most of people are able to go home same day or next morning.
All right. And I got another question about the Medicaid. I just want to know, is covering or?
Yes, Medicare and Medicaid do cover these surgeries.
And how can I make an appointment? Like,
It's
they wanna
pretty
make-
much after the session, you can reach to us through our numbers. I have them on the screen, our website, our phone numbers. And all you need to do just ask for an appointment. We'll be glad to set up for you.
Yeah, because of coronavirus, you can see.
We do virtual meetings like these, like video meetings. And if you don't have like adequate laptop or something and you don't feel you're going to get all the information you need from that, we can meet one-on-one personally, yes.
All right. Thank you so much.
Sure.
Thank you for the question. We have two more questions actually in the chat. One registrant said, "Good evening. I'm wondering, are all procedures done in Newcastle or possible in Dover as well?"
Well, we don't operate in Kent General. We do operate in San Francis Hospital, American Surgery Center, Wilmington, and I think there's another location in Dover called Delaware Surgery Center, and it's approved for outpatient bariatric surgery.
And one more question. Would it be easier for coverage purposes to be referred to you from a primary doctor?
Well, it's pretty much depends on your insurance. Some insurance require referrals, some insurance do not. So if yours required, then you have to get that referral from a primary care doctor. And most of the primary care doctors in our area, in fact, has been supportive and encouraging for their patients because they know the benefits from this surgery. I don't think in the last 3 years I heard any primary care doctor is opposing bariatric surgery.
Good to know. Another question in the chat. They commended you for a very informative presentation. They continue to go on to say, "I am self-employed, so I can return to work at the level I'm comfortable with because it would not be advised to sit too long. Also, I pay for my own insurance policy. I believe they do not cover the surgery. What does the sleeve cost if I pay out of pocket?"
Well, every place have their own arrangements. I personally, when I get questions like that, what we can do is set you up to talk to the right person in our practice. Our office manager can set you up with a finance office and exactly tell you how much everything costs.
Good to know.
But roughly,
does anybody have any other?
Yeah, roughly most of the places charge around, I'm sorry to interrupt you, George. Most of the places charge roughly, I think, around $25,000. Some places are less or more, depends on their cost of operation.
Very interesting. Very, very interesting. Thank you for the presentation tonight.
I got another question.
Go ahead.
You do operation here in Newark, Christiana?
We do emergencies in Christiana. Like if someone comes in ER with a problem middle of the night, transfer from another hospital or something. But the bariatric program for Christiana runs through Wilmington Hospital. That's their decision as a hospital. Many years ago, our group used to do surgery there, but they acquired Wilmington Hospital and decided to push all the bariatric surgery to happen in Wilmington Hospital. If you choose that place for surgery, we do it for you there? Of course. But just have to tell you something very important. It's a good hospital. It's a center of excellence, and we'll do good service for you there. Their dietitian program and psychology program is much different. They do charge you some money. So just be aware of that difference.
Thank you. Does anyone have any other questions while we are here?
Thank you.
I'm fully open to that.
Thank you so much.
Well, if we don't have any other questions, thank you, Dr. Ibrahim, again. And thank you, everyone, for attending our online seminar. Please feel free to contact us.
I sent 2 questions in the chat.
Oh, there's another question. Okay. I've been seeing a dietitian. Will these appointments count?
Okay. That's a very good question, because it's one of the things you have done. You're trying to lose the weight on your own. So you've seen people, you're trying to get medications, you've seen nutritionists and dietitians. Well, here's the thing. What's their experience with bariatric surgery? Do they understand the surgery, how it works? What's the difference between a sleeve and a bypass? Because there's some differences between these surgeries. And if they don't have that kind of experience, then unfortunately your visits with them are not going to help you with progressing through the surgery.
They have also asked, another one of our registrants, if this is good for diabetic people and which option is best for someone looking to lose 100 pounds.
That's in fact a very great question. It's one of the strongest reasons to do bariatric surgery is diabetes. Matter in fact, specialty of bariatric is called metabolic surgery because the surgeries we do affect your blood sugars and improve your diabetes a lot. Of course, the idea is not just losing the weight makes your blood sugar control easier. There's a lot of hormones that changes because of the surgery that help your body to control your blood sugar better. Now, to answer your question, bypass, sleeve, and there's a procedure we didn't talk about and called duodenal switch. The three of them improves blood sugar dramatically. The strongest one for diabetes is something called duodenal switch, followed by bypass, followed by sleeve. But you also have to look into things like what? How many years I have been diabetic? The longer I have been diabetic, the less the chance, or not less chance, the less the effect of the surgery. Meaning, let us say I've been diagnosed with diabetes 2 or 3 years ago. There's a great odds my diabetes will be gone with any surgery I do. What if I was diagnosed with diabetes 20 years ago? Well, the odds are much less, but the control gets easier, way easier with less medications. Now, every surgery you do, it makes you lose certain percentage of the excess weight, not the total weight. Meaning, let us say I have 100 pounds extra or mean more than normal weight, and I do a sleeve. I will lose around 65 to 70. I do a bypass, I'll lose like 75. I'll do the duodenal switch, 80. Does that mean I'll go all the way to the duodenal switch? No, because every surgery also have a side effect. Now, this is why the consultation in the office is important, because our talk tonight was just an introduction. There is so much science and fine tweaking. I mean, the preparation for surgery takes at least 3 to 6 months. Office visits with us, with a dietitian, with a psychologist, because there's much more information you need to know about the surgery. So losing 100 pounds, I have a patient I've seen today. She is a year out of sleeve. She lost 112. I have a patient with a bypass, lost 120. Okay, any surgery can make you lose that weight, but choosing the right surgery for you is an art.
Dr. Ibrahim, we have another question. Is the recovery painful? What can we expect during the 2 to 3 week recovery period?
Well, that's another good question. Well, now surgery has evolved. We have great advances in medicine now. It's not what it used to be. If you were getting surgery like that, let us say 30 years ago, you'll be in the hospital for a week because you're getting a huge incision on your stomach, hurts like hell. You can't get out of bed to go to the bathroom. You can't even take a breath. Now, what we do is done by very small incisions. We have great advances in local anesthetics. So now we do what we call nerve blocks to your stomach. So when you wake up, you are very comfortable. All the patients we do now, most of them are able to get out of bed and walk around within 3 or 4 hours of surgery and going to the bathroom. A lot of them go home same day or next morning. And matter of fact, because of that, we are almost now rarely would write any narcotics or opioids. We send people home on stuff like gabapentin, Tylenol, and ibuprofen, like stuff you will take for a knee pain or headache.
Very interesting again. Another question, is the recovery period pain comparable to a C-section?
Okay, that's a good way of measuring things. It's in fact a smart way of measuring things. You compare to something you encounter so you can measure with. Well, if you were able after your C-section the same day, get out of bed, walk around, go to the bathroom, then yes, I guess. I don't know how much time you need to drive your car, but after what we do, most of the people are able to drive 7 days out. I don't know if that answers your question.
I got another one. like the band one, is the same, like the cutting, or different? It's easier. Like if you do the band one, like tying in the stomach, you
I'm
can
sorry, I'm not catching you there.
the last one is not the two the first one.
Oh, the gastric band. Okay.
Yes, the band is easier than the first and second. Like you can,
No, it's
or
not really. All the surgeries are done the same way, the same number of incisions.
and you have to sleep all your body or just from in the back, like C-section. Like you do the C-section, like shot in the back and just from
We are
down
not
here.
doing any C-sections, okay? There's no,
I
C-section is a
know,
big cut,
but
big incision. We're not doing any of that. They are all small
like
cuts.
the sleep.
When you go
The,
to bed, you mean when you lay down?
yeah,
Just
you
in the
have to
first, yeah, you
sleep,
can
but
lay down in any position. That's not a problem with
no, I
any
know,
surgery.
but
Just
they make
whatever
this
comfortable
sleep
for you.
for a whole body, like make all your body sleep, right? For
Yeah, you mean anesthesia? Yes.
yeah, it's not
You're under full anesthesia for any surgery we do.
it's not like a C-section one.
No. Oh, I see what you mean. You mean epidural anesthesia.
Yeah.
No, it's a general anesthesia. You'll be sleeping completely. You're not gonna feel or remember or know anything. For you, it will feel like a blink of an eye.
Thank you, Asia, for the questions and the insight. If anyone else has any questions, please put it in the chat. Anyone at all? But if not, I'd like to thank you all again for coming, and thank you, Dr. Ibrahim, for participating. And as we were concluding, another question popped up. Thank you for utilizing the chat bar. They asked, does it feel anything like a tubule?
You mean like a tubal ligation? They are the same kind of incisions. They are very small. So more or less, yes. They heal the same way and they hurt almost the same thing. Yeah. Or if you had a laparoscopic gallbladder removal, it's similar to that. Or if you have a laparoscopic appendectomy, it's very similar to that. Yeah.
Wow. Very cool. All right, well, being that, Jasmine Ralston has raised her hand, I believe. Or clapped, one of the two.
Just clap. Thank you.
Thank
All right.
you.
Well, thank you, Dr. Ibrahim. If anyone has any more questions or would like to contact us, please feel free to call us and we'll schedule a consultation. But as for that, everyone have a good night and thank you again for coming.
Thank you. You too. Thanks for the information.
Absolutely. You guys have a good night.
Good night.
Thank you for your answering question.
Good night.